Hi, I'm Joseph Gauta. I'm a urogynecologist in Naples, Florida. My practice is the Florida Bladder Institute. And as a urogynecologist, I get asked by a lot of gynecologists who refer their patients to me to perform in-office procedures. One of those is simple hysteroscopy. Patients with abnormal endometrial biopsies, postmenopausal bleeding, stenotic cervixes in the office, or just a poor pain tolerance with other physicians' procedures, come to the office and have their procedures done. I get mine done very effectively thanks to the GStirrup because it stabilizes the patient's legs and gives the patient a sense of mental and physical comfort while I'm performing the procedures. Let's talk about hysteroscopy for just a second. I typically either use the EndoC device or Lena has a great surgical hysteroscopic disposable scope. I usually give the patient about 600 milligrams of ibuprofen orally the night before. And if the patient is nulliparous, I might even do 200 micrograms of Cytotec, which is misoprostol, orally the night before also to help soften the cervix. Upon arrival to the office, if the patient has anxiety or poor pain tolerance, they can take a Xanax 0.25 milligram or a standard 5 milligram Vicodin orally at the time of their arrival to help kind of keep them comfortable during the procedure. We also give them 30 milligrams of Toradol IM right into the thigh upon arrival. By the time the patient is situated in the stirrup in a standard GYN table, nothing fancy, I do a paracervical block with somewhere between 5 to 10 cc's of 1% lidocaine. I have a few little tricks for this too. I bend the 3.5-inch spinal needle a little bit at the tip so that when I enter the cervical canal, I can use that bent tip to inject the cervical canal a little bit, especially up near the internal cervical os, where a lot of the discomfort comes from the cervical dilation. I use an EndoC device for the hysteroscopy in my office, but once in a while I'll go ahead and use a rigid 3.5 millimeter metal scope also with normal saline as your distension media. This gives you great visualization, whether you're using a rigid scope or a disposable device. And using Takahashi forceps or small banjo curettes or even a Tischler style IUD forceps removal clamp, you can usually get the polyps or removal of the IUD performed very easily without any extra discomfort to the patient or any extra medications needed. I also perform either an endometrial biopsy at the same time, or we can do a full DNC if the patient can tolerate it. And we also perform endometrial ablation in the office after these procedures are done. This is all basically a la carte based on the patient's needs, but I will tell you that the GStirrup is 100% of the time in my surgical armamentarium when I'm performing these procedures on the patients. I don't think that the patient would be comfortable in any other position without these GStirrups.